Great. We can go ahead and get started. So my name is Homira Osman. It is such a privilege and honor that I get to moderate part of the session for today and also take a little bit of time to introduce you to Muscular Dystrophy Canada. I did want to again welcome all of you and really thank you again for taking time out of your Saturday to be part of this event. It sounds like by showing up in this room that you are part of the myasthenia gravis community, whether you're personally affected, whether you have a loved one, whether you work for a cause that helps to advance care or treatment. So thank you for the work that you get to do. And so, as mentioned, I wanted to introduce you to Muscular Dystrophy Canada. Many of you are familiar. I see a lot of familiar faces, people who are part of our organization, who support our work, or who are members. And so I wanted to start off by saying, as you could probably tell from our name, we're an umbrella organization. Muscular Dystrophy Canada started 71 years ago in Canada. It started when a family had a child impacted by a condition called Duchenne muscular dystrophy, and together with their physician went to the Canadian firefighters. At that time, they went to Toronto Fire, and they looked to raise funds for neuromuscular research, at that time Duchenne research. And the initial funds that were raised at Muscular Dystrophy Canada was through a partnership with Canadian Fire, and also that went towards research. So for 71 years, we've been funding research, and that really is in alignment with our goal as an organization, which is to advance and support treatments for any of the neuromuscular conditions that we cover. There are no cures, but we're really pleased to see some disease-modifying or targeted biologics coming into play. At the same time, the organization the past 71 years has said, yes, important to invest in the science, important to invest in the tomorrow, important to invest to get closer to those cures. But at the same time, in the here and now, it's important to build community. It's important to answer complex questions that is emerging. It's important to build community like this and offer peer support. I did want to mention that we are accredited by Imagine Canada, which is the highest accreditation a health charity can get in Canada in terms of how we use those funds that we're entrusted with. We continue to be a partner with Canadian firefighters. And, you know, I myself don't have lived and living experience with myasthenia gravis, but at our organization, we follow very closely this principle of nothing about us without us. So people on our board of directors have lived experience with neuromuscular conditions. When we run a myasthenia gravis initiative, we're really grateful that we have individuals like Margot has been a partner on our projects and have helped us to move the work in that person-centered way. Again, as I mentioned in the opening remarks, something we often say is individually rare, collectively common. Myasthenia gravis is one of the conditions that we cover at MDC. I see it as a strength. So for instance, there were times, right now we're in an era where there are treatments for myasthenia, but there was a time where there wasn't as much investment or progress in myasthenia gravis. When you work for an umbrella organization, you're able to stretch those donor dollars. So if there was, funding that was raised at a local walk and roll, and we had a good myasthenia gravis project come in, we were able to leverage those funds that were raised for the neuromuscular community to invest in the science. Or if there was an Ontarian with myasthenia gravis that came forward and said, I need help paying that 30% for this wheelchair. Ontario ADP is paying for 70%. How can I offset the cost? Again, being that umbrella organization, being able to provide that financial support has been really helpful. I also think about it in the era of treatments, though. What has also been helpful is we have experience now with treatments coming into Canada and the hurdles we already heard earlier this morning around access issues. So leveraging that experience. So for instance, with spinal muscular atrophy, another neuromuscular condition, there are now 3 disease-modifying therapies that are approved and available on provincial formularies. We saw the struggle and the challenges that we continue to navigate with that. So it's been really helpful now that when we see these new myasthenia gravis treatments come into play, who we can connect with, what tactics or ways can work best in influencing government decisions. At MDC, we often say when the healthcare system stops, Muscular Dystrophy Canada begins. That's really on the basis of when we know you get a neuromuscular diagnosis like myasthenia gravis, we understand that government can only do so much. Healthcare systems can only do so much. Private insurance, there are limitations there. And so this is where we see ourselves as a partner to the healthcare system and with individuals impacted to be able to support and a wide range of issues. So these might be some headlines you see in the media on a daily basis. We hear about this on a daily basis, ones that don't make the newspaper or a headline. But the scope of the work that we do is, yes, to access, treatments, yes, to access an earlier diagnosis, but navigating schools, navigating workplaces. We talked about home and vehicle modifications or equipment or accessible air travel. All of that is really important to the type of work that we do. I put this together in terms of oftentimes when I have like a quick 2-minute to tell people what MDC does, I say it's like the 4 Ps. We really invest in people, in projects, in partnerships, and policies. So when I talk about people, and I think it didn't show up, but when I talk about people, it is individuals affected by myasthenia gravis, their family members. When I talk about people, I'm talking about neurologists, physiatrists, allied health professionals who support the MG community. When I talk about projects, it's projects like our Canadian MG Journey Mapping Project, the research that we've supported. So for instance, we recently supported Dr. Barnett Tapia's research on looking at treatment preferences. When I talk about partnerships, I look at partnerships in terms of we have a clinician network called NMD4C, the Neuromuscular Disease Network for Canada, where neurologists and physiatrists and academics from across the country get to, especially in these rare diseases, get to work together on projects. And then policy, and you'll hear me talk about this, we have a couple of key goals. One is around early diagnosis. In the case of myasthenia, I don't anticipate our advocacy will be that it's through newborn screening. That doesn't make sense, right? Given the cause of the condition. But what we're strong advocates for is how do we diagnose this condition sooner? Far too often we hear that individuals go 3 years, 5 years, up to 8 years. When they reflect back on the time of first bothersome symptom, they say it was many referrals, many appointments, many misdiagnoses until I got this diagnosis. I vividly remember through our myasthenia gravis journey mapping project when someone in BC shared with me, I received an ALS diagnosis. I was told I have up to 2 years to live. And, I sold my home. I celebrated my child's birthday as though it was last, all of that. And then I found out it was myasthenia. And then I was told, well, you should be lucky and dismissed. But that trauma of that misdiagnosis. And then also, this is still a condition that comes with challenges. So it's a relief, yes, that it's not a 2-year life-limiting condition, but there's still a lot of challenges. So I often think about early diagnosis in that way. We are agnostic, similar to the Smire Foundation in terms of treatments and therapies, but we are high promoters around treatment choice and access. So we have an op-ed actually coming out very soon in Healthy Debate, really talking about that there are some rules now in treatment access that stop clinicians from having that choice to work together with you as a patient on what would be the best treatment choice. Another policy issue is, yes, the name is myasthenia gravis, but what can come with it is mobility disabilities or invisible or non-visible disability, really advocating for disability principles and support. So we were huge in getting the Canadian Disability Benefit, the CDB, introduced this past year, and now we're actively working on making sure provinces have no clawbacks, meaning that if you receive other tax credits or other disability credits, that won't be used against you when getting your CDB. So access to treatments, access to an early diagnosis, and access to disability supports. And you'll hear me talk about today also the costs related to living with myasthenia gravis. Oftentimes, and we already heard on the patient and the clinician panel this morning, that these new treatments are considered to be expensive. We hear that term, right? There's a price tag to it. And so oftentimes we focus on that, but what we don't focus on and the work that we're trying to do is collect the information on the cost of living with a neuromuscular condition, cost of living with myasthenia gravis. Oftentimes we're really thinking physician visits, the cost of that, or the medications, the imaging tests, the laboratory tests, the antibody testing. But there are some non-healthcare and indirect costs as well, such as physiotherapy, such as home and vehicle modifications, transportation to appointments. I bring up this example quite a bit, where I have individuals share with me that when they have an appointment here in Toronto at the Prosserman Neuromuscular Center, they get a hotel room to stay the night before just to make it to their 9 a.m. visit, right? And so there is a cost to that. Time away from work, time away from school, time away from other commitments, assisted devices. Oftentimes we think that individuals with myasthenia gravis might not need the level of supports or aids, but especially since that there's that fatigue or changes in your condition throughout the day, there is value in assisted devices. And as I mentioned, in Ontario, some of these devices are covered at 70%, like a wheelchair. Some are not covered at all. And then, as mentioned, the work loss productivity. So we did some work together with health economists and neurologists to capture the costs of living with myasthenia gravis. And back to the treatments piece, yes, these treatments are quote unquote expensive, but we have mechanisms in place in Canada where a drug is reviewed for safety and efficacy through Health Canada. It is then evaluated by our drug regulators to make sure that there is value for the science that is offered. And we have price negotiators, the PCPA. So once it is approved and a price is negotiated, we do believe then at that point, clinicians can introduce that as a choice. And we also know that sometimes these high-cost treatments, when introduced earlier, might stop the irreversible damage or the need for perhaps a mobility aid or the work loss productivity. In our study, we learned that many people engage in early retirement because of their myasthenia gravis. So when we talk about dedicating supports, MDC has our equipment program. We do this out of protest. We do not want to be in the business of funding, wheelchairs, home modifications, bathroom aids, but we know we need to do this right now because this is a cost for many individuals with myasthenia gravis and family members, and at the same time working with government on helping them to understand how important it is to cover these pieces of equipment. We also believe that there's opportunities to connect like we are today with one another, but especially as an organization that represents different neuromuscular conditions, we have opportunities for you to connect with people with other neuromuscular conditions. Again, like today with the Homira Foundation, this partnership has been great, where you get to connect with patients who don't have myasthenia gravis, but perhaps similar related health experiences. And in 2026, we're launching our first ever MG peer support group, offering both virtual and in-person opportunities. One of the things that we do at MDC is help to connect you to a healthcare professional. Yes, that might take that might immediately make you think, okay, you can help me find a neurologist. Yes, we can do that. We have a growing list based on anyone who registers with us. We see who their neurologist is, but we now are modifying that to also include allied health professionals. So who's that massage therapist that has experience with MG? Who's the PT in Ontario that has experience with MG? Who's the dietitian? Those are pieces that we have there as well. A lot of information, a lot of misinformation on myasthenia gravis. In our Canadian journey mapping study, we heard that typically at the time of a diagnosis, very little information was given. I heard far too many stories of like when the clinician left, I Googled it, or I overheard the clinician speaking to residents about it, and that's how I learned about MG. We want to change that. We also know that there's a lot of information, right? And navigating that can be challenging. So if you have a question on how much exercise, how little exercise, what diet, is creatine good or not? Should I be on a GLP or not? Should I, what do these guidelines really mean? That's something that we can help. And if the evidence isn't there, we have an Ask the Experts panel that we reach out to say, based on your clinical expertise, what is the best way to navigate this question? And so talking about life with myasthenia gravis, we also have system navigators throughout the country. If you need help with housing, home modifications, transportation, tax credits, benefits, equipment programs, and community resources. Many of you participated in our MG journey mapping study in Canada. This is just the infographic, and our publication is being reviewed, but just some highlights. This is really what has this study. We interviewed 108 Canadians with a confirmed diagnosis of myasthenia. What was really clear here is there is several misdiagnoses along what we call diagnostic odyssey. It took about 5 years, 6 misdiagnoses, 7 different healthcare professionals, 9 different clinic visits, people coining themselves frequent flyers of the ER, being put on treatments like a prednisone without much discussion around the implications of that, or even today being on prednisone without bone density scans or monitoring. Yes, this demonstrates the challenges, but it also demonstrates the opportunities that we together with patients, with people with experience, with partners, can help to influence and make this journey better. These are some images that, as part of that journey mapping study, yes, we had interviews and we also had questionnaires like the MG-ADL that we had done. But we also had individuals select a photo, either that they took themselves or that they found online, that reflects life with MG. And so you can see, for example, someone had chosen Cinderella in that pumpkin carriage to reflect that sometimes that's what it feels like. It feels like, you know, I run out of that energy, I become more fatigued, and I don't have that ability to move forward. Or that calendar was life revolves around IVIG. Life, my family's life, my children's activities revolves around that IVIG appointment. She was coming in from BC and would have to go on into the city, and said that we all have to really work around that every 3 weeks IVIG. And that blue-eyed monster reflected life on a prednisone. So I wanted to take a moment to explain our why. So why is MDC continuing to do the work that we do? We know that MG affects Canadians across different provinces or territories, individuals of different ages. We also understand that there are people who are connected to us, but there are many people who are not yet given a diagnosis of myasthenia, and there is an opportunity there to support, again, with the early diagnosis and the connection. And in 2026, we're launching what's called For Us, By Us, a patient-powered registry for MG. I see this of value for a couple of reasons. One of which is, especially in the era of new treatments, that data on healthcare resource utilization, that data on quality of life, that data on purely what your type of MG is needed. There is no MG data set in Canada right now. We are not capturing clinical outcomes, but we need this information to help you in terms of accessing new services and supports. But what we really need, and I'll be working with many of you on the continual design of this, is you can also see your performance against other people with MG, against other people with neuromuscular conditions. You can print it out. You can save a copy and take it to use it as a tool with your healthcare professionals. And then similar to the Smyra Foundation, we also fund myasthenia gravis research. I mentioned for 71 years that's been happening. And an example of that is we funded the study on how people with MG make treatment decisions by Dr. Carolina Barnett-Tapia. This will continue to be important for us. So these aren't all, but these are some of the new treatments that have been Health Canada approved or coming to market. This is also where this is behind our why. The why is, yes, there's been such good innovation, great progress, but they're not in reach. Approval does not equal to access. And that's where organizations like ours work together with individuals with lived experience to help move this forward. MDC is not a lobbyist, so what we do is more evidence-based advocacy. So, for example, with that op-ed, looking at guidelines, looking at best practices to say, that op-ed is really about that for one of the products, Vyvgart, you need to, in Alberta, demonstrate treatment failure on a drug called rituximab. And so that is a problem. That is a problem. That drug has not been studied for myasthenia gravis. That is a challenge because during that trial period, you can actually have damage, irreversible damage. You can go into myasthenic crisis. We are all for clinicians being able to leverage and use off-label products, but it shouldn't be a requirement. So when I put up this slide, I'm really saying our why is there's still a lot in terms of making sure individuals have access to new treatments and therapies. And sometimes when we're thinking about our quote unquote super specialists, maybe individuals who are the neurologists, they might be aware of these new treatments. Another piece is people in the community, your family doctors, or community neurologists. One learning from the Canadian Journey Mapping study was that people said, I have to be the one to explain to my healthcare providers what MG is. So now imagine when 4 or 5 treatments are coming in, does that actually encourage more conversation, or will that inhibit conversation of like, that's too much, and maybe a hyper focus on IVIG or on prednisone? How do we facilitate that? So there's a lot of opportunities here. I put trial readiness as well, because I do think that as an organization, we are encouraging more clinical trials to happen in Canada. Typically, we're not selected in Canada for clinical trials. It's the US and Europe. We have excellent clinicians and resources to run clinical trials. From the patient perspective, clinical trials are important because you get to access innovative therapies sooner. Sometimes it also puts you in an opportunity to have more follow-up and better monitoring. But typically we're not selected. And so that's some of the work that we're doing is when we think about myasthenia gravis, how can we have access to those clinical trials? We did a treatment journey study as well. And so I just wanted to put up, this just highlights what we spoke about already, right? Which is to say there are barriers to accessing targeted biologics. And this is a key focus of ours as we go into 2026. For those who have already accessed targeted biologics, there have been some benefits that they have really been highlighting, particularly in terms of how they participate in life, the convenience of the level of dosing, the improvements in side effects from other medications. And, you know, it is also really important as an organization that we think more holistically. These treatments can also only do so much. And so complemented with exercise and diet and other, as you know, you work with your healthcare team are really important. So that is a rapid round introduction to MDC. I welcome you to connect with us. I should also mention that sometimes as an organization we cut up here, you know that there are other disease-specific organizations. For us, it's all about partnership. When you think of those advocacy issues, there's a strength in numbers. And so we welcome to work together with partners in influencing change. And so yeah, I'll be here today moderating the clinician session and then the patient panel, but happy to take any questions before we move into the panels. That's a good question. So why is there limited trials in Canada is a question. We have done some work on this to identify. It's multifaceted. One of which is sometimes for neuromuscular conditions, we find that it's global that tends to make that decision. And so Canada doesn't have, the Canadian affiliate for that company doesn't always have that input in influencing that. The other piece is sometimes we have found that industry partners have selected the US or European countries because it helps them to get FDA approval or EMA approval sooner. The other piece is sometimes we don't socialize that specialist that we have in Canada and the capability that we have in terms of some of our larger neuromuscular centers in conducting these trials. The other barrier is that our start times are slower than other places. I'm working with British Columbia right now. It's taking 9 months for a trial, just purely on ethics to be administrative, like rollout. In 9 months, the US sites have already collected their data. So you can see why an industry partner would go there, right? At the time we're starting up, they're closing out their project. And so there are challenges there. That's where we as an organization are really working on building clinical trial capacity. How do we think about building clinical trials even outside of Toronto with the number of treatments that are coming in? If I'm going to use him as an example. Dr. Katzberg is running all the MG trials in all of Canada. That also doesn't make sense because there's a concentrated population of MG patients with MG in that city. So how do we help Vancouver? How do we help in Manitoba, in the Atlantic to have these trials as well? So simultaneously working on trial capacity, but also this piece around reducing the administrative burden or startup for it. But when you think about these new MG treatments, the majority, if I'm not mistaken, didn't have trials in Canada. Okay, wonderful. With that, we'll go ahead and move into our clinician session. And of course, I'm here throughout today and the conversation doesn't stop here, so feel free to connect with me.